Okay, I think we're back on now. So the way the afternoon is going to go is there's two parts to the abdominal trauma. The first part, I'm really just going to focus on general things, and then the second part we'll do some organ-specific stuff. I have some questions that are embedded in the talk, and so we'll be going through some cases, mostly cases, that I think are fairly reflective of what you're going to see. I'm always nervous about giving this talk because this is what I do. So I have to be careful to make sure that I'm telling you what I think you're going to see as opposed to what I would do, which is not always the same thing. So if you do see something in the syllabus or you have a question, please interrupt me. I've practiced it enough. I think I'm not going to be injecting too many of my own biases, but if you do catch something, please, bring it to my attention and catch me with it. So a lot of the stuff in the first part I'm going to try and go through fairly quickly. They ask us to include a lot of information for you in these talks. I think that it's important. You should have this information, but I want to focus as much as possible on things that I think you're going to see on the test. So when we talk about abdominal trauma, the big things that we're concerned about, the two break points, I would say, are the mechanism, and in general that's blunt or penetrating, and then the physiologic status of the patient, hemodynamically normal or hemodynamically abnormal. And a lot of the decision making that you make and a lot of the questions that you're going to get are going to be based on those two things. What do you do with a hemodynamically normal patient with blunt abdominal trauma? What do you do with a hemodynamically abnormal patient with blunt abdominal trauma? What do you do with a hemodynamically normal patient with a gunshot wound to the back as opposed to the hemodynamically abnormal patient with a gunshot wound to the back? So think in terms of those kinds of break points and look for those kinds of buzzwords or information that will lead you one way or the other when you're looking at these questions that you get on abdominal trauma. And again, trauma in general is roughly about 10% of the whole test. It's a little bit disconcerting to me that infectious diseases is actually more, but for surgeons, but in any case, abdominal trauma, abdominal, chest, head and neck, brain, that's about 10% of what you're going to see. So plan on 20 to 30 questions on average that you're going to see. Yes?
About the numbers, there might be some argument about.
Yeah, so I'm putting some of the stuff, no, I don't, so a lot of the stuff, and I'll try and just remember to tell you. So for example, these kinds of numbers, the kinds of things that you might be asked here are if you have somebody with penetrating abdominal trauma to the anterior abdomen, what are the most common organs that are going to be injured? Small bowel is going to be up there. If they ask you what's the most common solid organ that gets injured, it's going to be liver. That kind of stuff you might see. Those are retention questions that you might see, but the majority of the questions that you're going to see are synthesis questions. They're going to give you a patient who has had something happen to them, and you need to figure out what to do. That's the majority of things. So if you have to stratify according to what you're going to study, I would not focus on the retention stuff because most of the questions are not going to be retention. Most of them are going to be synthesis. If you happen to come across some of these numbers and you happen to remember it, yay, but I wouldn't spend a lot of time trying to do factual stuff, particularly with abdominal trauma. Focus on, when you're reading questions and reviewing, focus on synthesis type situations. A patient in a particular scenario looking for the things in that stem that will tell you what it is you want the answer to be. So I will try and separate those things out as we go through. Unless that's what I've said. Some of this stuff, the epidemiology stuff, I'm going to run through fairly quickly. It's more for your information. There's a chance that you might see something about it, but I would not focus that as the studying. I would not focus on that. I would focus on trying to, as you're reading questions, and I think that's the best way to review for these kinds of tests is to just go through tons and tons of questions. Focus on the questions that actually give you a patient because that's the majority of the types of questions you're going to see, unless there has been some dramatic revamping of the exam in the last 3-4 years. So with blunt trauma, a lot of times we're talking about direct impact types of problems as well as compression or crushing, and you'll look for that type of information in the stem. Was the patient pinned between, say, a truck and a wall? In a situation like that, you want to look for signs of a crush injury. You want to look for signs that there's been muscle damage, rhabdomyolysis, things like that. For direct impact type questions, they give you the patient who directly impacted their epigastrium up against a dashboard or on the motorcycle handlebars or things like that. Start thinking duodenal hematoma. So look for those kinds of clues with the mechanism. For penetrating trauma, pay real close attention to the location of the wound. So is it a flank wound? Is it a purely chest wound? If they give you a penetrating question where they say that it's a stab wound to T9 or around the level of the 9th rib, now you've got to start thinking about there may be abdominal trauma as well as chest trauma. So for penetrating trauma, pay real close attention to the location. For blunt trauma, pay real close attention to the type of mechanism that they're giving you. And again, just to review the anatomy, we're talking about in the abdomen, there are actually 3 cavities in the abdomen. So there's the peritoneum that sits anteriorly, the pelvic retroperitoneum, and the retroperitoneum proper. That is important when you get questions on blunt abdominal trauma, trying to diagnose what's going on. Am I worried about pelvic fractures? Is that the mechanism that I've got? Am I worried about mostly peritoneal injuries? Am I worried about retroperitoneal injuries? So when you're talking about abdominal trauma, that becomes important. For penetrating trauma, we talk a lot about boxes. And again, it's the location of the wound. So if you have a stab wound to the anterior abdomen, that is treated differently than a stab wound to the back flank in a hemodynamically normal patient. And we'll talk a little bit about that. So we have the anterior abdomen, which is really the anterior axillary lines forward, above the groin, inferior to the costal margin generally, or at least inferior to the nipple. The flank, sort of the anterior axillary line to the posterior axillary line. Usually we refer to the flank and the back together. So anterior axillary lines back, all the way back is the back flank. And then superimposed on top of that is the thoracoabdomen. The thoracoabdomen is 360 degrees around, so you can have a posterior thoracoabdominal injury penetrating, or you can have an anterior penetrating thoracoabdominal injury. So if you look at these things, for penetrating trauma, a stab wound, for example, to the anterior abdomen, one of the things we have to worry about are, most common solid organ injury would be liver, because it's just so big, and then the most common non-solid or hollow visceral injury would be the small bowel, because that takes up most of the mass in the peritoneum. For back and flank, we're worried about retroperitoneal structures. So for a hemodynamically normal patient with a back flank wound, the thing we're worried about are retroperitoneal injuries, injuries to the retroperitoneal colon, to the pancreas, to the kidneys. That's what we're looking at. So again, for blunt trauma, the mechanism is going to give you a lot of information about what in that question they want you to look for. For penetrating trauma, it's the location of the wound. That will help you figure out what they want you to look for. And again, obviously, in all of these, the physiologic status of the patient. For a hemodynamically abnormal patient, there's a certain amount of information I want. Frankly, do I have something that tells me there's blood in the belly? I don't care where it's coming from. In a hemodynamically unstable patient, I don't care where the blood is coming from. I just need to know it's there. For a hemodynamically normal patient, it's important for me to actually figure out where the blood or where the problem is. So the tests that I'm going to do are different, and we'll talk about that as we go on. So the first case is a 24-year-old male who is in an MVC. He arrives with a blood pressure 86/40, or 86/60 rather, heart rate 126, Glasgow of 6. So this is a hemodynamically abnormal patient with blunt trauma who also has altered mental status. Okay? He has a large abrasion over his right upper quadrant. He grimaces to palpation of the abdomen. His abdomen is distended and tympanitic. He has a deformity of the right thigh. What's the next step in the management of this patient? Somebody yell it out. Airway, right. So the thing they will get you on is that you have this patient who has all these signs of abdominal trauma, and you've forgotten the ABCs. You've got the next step in the management of this patient is the primary survey, right? So you attend to the airway, you listen to his breath sounds, you do the ABCs first, and then once you've got the airway and the breathing figured out, then you move on and figure out what's going on with his abdomen, because even though they've given you all these signs of abdominal trauma, he could in fact be bleeding into his chest. right? The reason he's got a distended abdomen could simply be a reactive ileus to a solid organ injury that doesn't require operation. So you still have to do your primary survey. So that's a typical question where they will get you on the fact that you didn't intubate the patient. They're in the STEM, it'll read like that, and then your answers will be things like, do a fast exam, get a pelvic film, take the patient to CT, intubate the patient. That's the sort of thing that they'll get you on. In the secondary survey, once you have the patient stabilized, then you can start moving on to all these other things. But the answer to this question is you do that primary survey first. So on physical exam, we have a patient who's got some external signs of abdominal trauma. He's got abrasions, he's got a distended abdomen. You can look at the flanks if they got ecchymoses, you're worried about renal injuries in that situation or spine injuries. You can assess the stability of the pelvis, sometimes you can't. You should probably still do a good perineal and rectal exam with blunt or transpelvic penetrating trauma, not so much because the rectal exam is really that reliable, but because if you do have a hematoma or blood, then that does give you a sense that there might be a significant injury. Part of the problem with abdominal trauma is that, though there are several of us in the room who've been doing this for a long time, and I will say my abdominal exam in trauma, particularly blunt trauma, you might as well just flip a coin half the time. So a lot of times you can't get a sense of whether or not someone has abdominal wall pain or whether they truly have peritonitis. Put on top of that somebody who's got, either been drinking or they have a head injury, then your abdominal exam also becomes unreliable. So a typical STEM for this type of question would be the patient who comes in who's jumped into an empty pool because he was high, and he may have several things going on at the same time. He may have a head injury, a spinal cord injury, and an abdominal injury. And the typical question will be they'll give you someone who is in what the vital signs appear to suggest neurogenic shock, right? It'll be someone who's hypotensive with a normal heart rate, say a heart rate in the 60s or 70s. And they'll ask you, they'll get you to intubate the patient. The patient has a normal chest x-ray. What is the next thing you have to evaluate? The next thing you actually have to evaluate in this abnormal patient is whether or not they're bleeding into their abdomen, right? Even though the vital signs suggest to you that they may be in neurogenic shock, that may be true, but the next thing you have to evaluate is do they have hemorrhage from somewhere? All right, so you need to look for those kinds of things in these questions. So in our patient, the patient gets intubated. We've got good color change on our CO2 colorimeter. We've got equal breath sounds. So again, the STEM is trying to tell you, don't worry so much about the chest right now. The chest is actually doing okay. We get a couple of IVs in. We start him on some LR. He doesn't get any better. So the blood products are ordered. What's the next thing we're going to do with this patient? Is we do something to assess his abdomen, all right? Now he's hemodynamically abnormal. What are the 3 tests that we can do to evaluate the abdomen just in general, regardless of hemodynamics? Fast, DPL, and, so what are the 4 things? So forget the hemodynamics for a second. There are 4 things you can do to evaluate the abdomen, right? You can do a DPL, which I think we're the only place in the galaxy still, Cook County, that does DPLs, but a DPL, a fast exam, a focused abdominal sonogram. You can do a CT scan, or you can take someone to the OR. So only 3 of those should be considered in a hemodynamically abnormal patient. The FAST, the DPL, and go to the OR. You shouldn't be taking a person to CT scan with the vital signs that we just gave you. So if that's the answer, if that's one of the answers in this scenario, that's a wrong answer. Okay, so since this patient is not hemodynamically normal, the only thing I need to find out is there blood in the abdomen? That's the only thing I want to know. I don't care where it's coming from. So the CT scan is not only not useful, it's potentially dangerous, because now I'm taking this abnormal patient over to CT scan and then he codes there. All right, so does that make sense to people? You're looking at mechanism and you're looking at the hemodynamics. For a hemodynamically abnormal patient with blunt abdominal trauma, if CT is one of your answers, it's the wrong answer. So DPL or FAST would be okay. Going to the OR would be okay, and we'll try and do some sort of sort out how to figure out what to do there.
If part of the answers, or if they want to choose between DPL or OR in this patient, maybe we would you actually do a DPL or would you go to the OR?
So the question is, if you had to choose between DPL or OR in this patient, so this is what I would say. You've got, they won't give you that.
Right.
What they'll give you is, they'll ask you what sort of test is appropriate to do. And they'll have you choose from a set of tests. And then you have to pick. They probably won't give you DPL versus FAST because they're equivalent tests, basically. So it will be a choice between continued abdominal observation, CT scan, FAST exam, or some kind of or angiography or something like that. They'll give you something like that, and then the answer will be the FAST exam. Sorry. Okay, this may happen a lot, so can you hear me without the mic? Hopefully, yes. But anyway, so that's what the STEM will be, what we have, and then the answers will be a set of tests to do. The person that they give you who has to go to the operating room will have something obvious. It'll be either you've exhausted your exams and the patient is still incredibly unstable. In that case, you go to the OR. Or it will be someone who comes in with a back flank injury, a penetrating injury to the back and flank, who is hemodynamically abnormal. In a normal patient, we would say get a triple contrast CT. In an abnormal patient, the answer would be you go to the OR. You know, you don't get any more tests. Okay, so those are the kinds of things that you need to sort out. And again, I don't always like the trauma questions on these exams, but they aren't so granular that they're trying to trick you. Most of the time, I think. So, okay. Yes?
Some of those questions are coming from the oral boards, and there are 3 big oral board questions to deal with unstable patient and trauma.
Mm-hmm.
And what we don't want the applicant to do, or the candidate, is to take him out of the trauma room to anything but the OR.
Yeah.
If he takes him to the CAT scan, patient sort of dies. If he takes him to angio, patient dies. So they want to push you not to, well, we want to push them to take them somewhere other than OR. If they can resist that, then it's good.
Right.
They can't, so yeah, there is some evilness in that, but it's, yeah, it's kind of.
But it makes sense. I mean,
Why do you want patients not to code?
yeah, but they won't. They won't give you a choice between doing a FAST exam and going to the OR. It'll be CT scan and OR, or CT scan and FAST. And the answer would be you do something that you can either do at the bedside, or if you have to leave the trauma bay, you're going to the operating room. Okay, so they won't try to trick you that way. Okay. Any other questions about that? And we'll do a couple of cases, and we'll do a couple of scenarios to talk about that. So again, the next step in the management of this patient is we have to figure out what's an appropriate test. And in an unstable patient, the appropriate test is either a DPL or the FAST, or if you don't have those available, to the OR. But again, they will give you a choice of tests, or they'll give you, do something that's clearly wrong or go to the OR. That's the way they'll set that question up. The exception to all of this is going to be the patient who has the bad pelvic fracture. So if you'll remember, those of you who've taken ATLS, there's that whole algorithm about how do you manage the hemodynamically abnormal patient with blunt trauma who's got a pelvic fracture. So if you have that patient, again, the break point is, are they hemodynamically normal? If they are not, the first thing you're going to do still is you're going to get one of these tests, either a DPL or a FAST. If those tests are negative and the patient has a significant pelvic fracture, then it is appropriate to take the patient to angio in order to perform an angioembolization. Okay, so for most of the abdominal trauma, it's going to be assess the peritoneum, make a decision based on that. That's sort of the basic blunt abdominal question that you'll get. If you have the patient who also has a pelvic fracture, it'll be still assess the peritoneum, and only if that assessment is negative, then it's okay to take that hemodynamically abnormal patient out of your trauma bay to go to angio. Okay? Now, I've put some slides in. We'll talk about DPL FAST, and I also put some slides in about pelvic fractures. Again, You don't need to know. I'm not going to spend a lot of time on the how to do it because they're not going to ask you that. This is just for your information. The thing that's important on this slide is that DPL is a highly sensitive test. It's not specific at all. So again, it's only useful in blunt trauma. It's only useful in hemodynamically abnormal patients where you want to know, is there blood or is there not blood? That's the thing you want to know. Okay? And again, I'm not going to go through all of this because you have it. You have it in your syllabus. There's a lot of controversy about what constitutes a positive DPL, but in general, if you put a needle in somebody's belly and they're lying on their back and you aspirate and you get blood, there is ton of blood in the belly, right? Because it means that they're lying on their back and the blood has to have accumulated far enough up that you can reach it with an 1.5-inch needle. So if you aspirate somebody's belly and you get blood, there is a ton of blood in their belly. The more specifics about, what's the right count and things like that, I have never seen that on the critical care exam. Never in 3 times, I've never seen it. So it's more a question of sorting out DPL is a sensitive but not specific test.